You are listening to Midday. I'm Maria Shilaos. As we take a moment each February to remember the contributions of Black Americans and celebrate the achievements of African Americans throughout history, one thing remains clear. Black Americans still face a number of disparities when it comes to getting health care. Dr. Richard Ferguson is the president of the Black Physicians of Utah, and he joined me to talk about the challenges and the potential paths towards change.
Let's just take one example, and that is blood pressure and heart disease. We'll go even larger because uncontrolled blood pressure can contribute to the leading killer in the U.S., which is heart disease, and for adults. So we have to understand that because of it's predominantly has a negative impact or disproportionate impact on African American men and women, because I like to kind of say like three things that have led to historical inequities and access to care that continues to affect African Americans throughout the nation today. And that's from those that live in rural areas to cities. And I would almost like to say, why would heart disease, which is improved because of improvements in science and in medications, but we also still have to understand why are African Americans more likely to die of heart disease than their white counterparts. So I think part of the things we need to understand is structural inequities drive risk. I often tell many folks, your life expectancy to a certain extent or your access to care is often defined by your zip code. It's so much can be drilled down to your zip code. My living in 84054 will be very different than someone that has a zip code in Kearns or West Valley. Maria, how many hospitals are out there? And how many hospitals am I near? So we have to think about healthcare often being seen as a resource. So often African Americans don't have the same availability to that resource. And then you have to complicate that with chronic stress exposure and just disease risk. So about 50% of African Americans over the age of, I would say 40, either have undiagnosed hypertension or already have hypertension, but may not be adequately managed. And then we have to also realize that there's access and insurance gaps. So when we still have a barrier to timely primary care, we also have to realize that Utah is like 42nd in the U.S. for access to primary care physicians. Necessarily building more med schools won't really address that, because if the doctors aren't required to stay in state and go into the specialties we need, we're still going to keep widening that gap of primary care access. So African Americans, one predisposition, let's just say, towards hypertension because of West African descent and genetics, but also that revolves a little bit around the air they breathe, access to healthy foods in the zip codes they live in. But if we just stay on the health side, primary care, specialty care, maternal care, particularly because Black maternal mortality rates are 3.5 times that of white women, and access to high quality facilities. So when I said, what's the difference between my living in 84054 versus someone with a zip code in West Valley, I have at least 4 hospitals I can easily get to in a matter of 10 minutes and specialty clinics. I can't say that for the west side of our city. And then lastly, I'd say what contributes to continued disparities is implicit bias. So this is often when you're acting on someone just based on the aesthetic, inconsistent communication, and a undertreatment of certain symptoms. So pain being one of those, chest pain particularly. So if we're talking about heart disease and often delay of care, it's been well documented that if you're a Black person going into the ED to have your chest pain treated, there's about on average 45-minute gap in you being provided the definitive steps in care, aspirin, oxygen, but more so importantly, receiving pain medication. That's been identified in multiple areas throughout our nation, not just say that would happen here in Utah. So this can lead to, that implicit bias can lead to misdiagnoses and just poor healthcare outcomes. And also can't forget that past harms. I don't like to often just reference the Tuskegee experiment, but past harms also reduce trust and engagement. So barrier physically to healthy foods, often access to adequate hospital specialty care, and then just the environment one lives in. You may not have clean water, clean air. If we remember Flint, Michigan, and what they had to deal with there, which is predominantly Black population, you can see how there may not be trust in government or in a health system that really wants to help you have a higher quality of life.
Yeah, what would be the number one thing you would say we could do?
Well, not to be a little biased to go with my prior term, but increase Black physician representation. Although we're only about 0.06% of actual doctors in the entire state, representation matters. I feel strengthening a pipeline programs such as that I have with our scholarship program that we have with our clinical research opportunity in the summer and just general mentorship, but scholarships retention is also important. So we can attract very talented Black physicians to our state. But if you don't make it feel as their home and they're respected, and they're less likely to face bias or microaggressions in their workplace, they're more likely to leave if you can't kind of provide that safe, protected space for them to learn and work. So patients benefit from culturally concordant care and systems that allow them to have better advocacy and accountability. Advocacy and accountability is something I stress often. And I think the other thing is we need to remove these practical barriers with community connected care. Invest in community health workers. Invest in mobile after hour clinics, more so after hours. If you have a lot of working class families, it's hard for a woman to go and get her mammogram done if it's not open past